think all that is there. So in a situation like this, where you think that you don't have any ways, especially in view of his history of previous tumor, that you can't give him a teriparatide or stuff like that to increase the improve the osteoporosis. And if that is the case, you need to protect him in some kind of as you said, a brace or a TLS or something for long term. But yeah, I have no experience of HA-coated screws. We are reading a lot about it, and actually the results are same as when you're using the cement itself. There is no difference in the results between the two.
I want to comment on the second revision. Actually, why did the first one failed? We must call that condition as a PJK, proximal junctional kyphosis, or proximal junctional failure. Is it right? Yeah. Yes.
Yeah, that's correct. That is correct. And so my point is that this did not happen gradually, what we normally see with the PJK. This happened due to a trauma. The patient had a fall.
Yeah. But it must be a minor trauma. There must be over stresses over there, and one critic here should be that you have stopped at L1 level, which is at thoracolumbar junction in the first surgery. This is one of the reasons of PJK. But so it could be done prophylactic vertebroplasty in above that level, T12, for instance, because the patient had got previous radiotherapy in the region and already osteopenic or even osteoporotic.
Mehmet, what about soft landing? If you use soft landing kind of screws just on the top as well?
Yeah, that it may be also another one. Yeah, good for discussion. These are all for discussions, and we always face such problems if we are making multiple levels fixations.
So there's a question. There's a question from a participant that the patient of Dr. PV hasn't restored insagittal balance. Anterior vertebral support would maybe should have been done. So, but obviously with this patient's clinical condition, high risk patient, you'd think 5 times before going anteriorly.
I will remind you that the general surgeons were not very keen to go there, and despite the patient, so the trauma was, I think, severe and significant because the patient had a ruptured gallbladder. So the trauma must have been severe enough for somebody after a fall to rupture his gallbladder. Yeah, maybe contribution for that is also the irradiation, but my main point is that the general surgeons in my hospital were not very keen to go in that abdomen because of very, very, very hostile abdomen because of irradiation. So and then I will think even not twice but 3 times if the general surgeons are not happy to go in the abdomen for me to go there and to do anterior surgery. I think that will be not very wise idea.
There's another question, Nikolai. Why did you use a connector for the rod instead of changing the whole rod, a longer one? Is that because it was MIS?
Yes. So I did not want to so the lower levels are also irradiated, and as it stands now, they are holding strong. And I am a very strong believer that it's not only the bones that we have to respect, we have to respect the muscles, we have to respect the ligaments. And we have a good fusion, good healing there. And I decided to leave the lower bit of the instrumentation untouched, and instead just to do a limited surgery and to use these connectors. yeah, there is chance that these connectors may fail me. Yeah, I agree with that, but I took the chance. I think with this kind of cases, there are not so many. We don't operate so many of these cases. This is definitely not the mainstream. This is not my typical case. Whatever I do, I try to apply everything that I know and that I've learned, but it's always going to be a certain dose of taking chance.
So there's another comment that that long construct putting the patients prone to more chances of harms in the way of screw failure, and we have already talked about it. Then there's a question about, in view of the post-op implant failure, probably as a result of the background osteoporosis, what other options should an upcoming surgeon consider to avoid this failure in the first place?
So this is not a typical osteoporosis case. This is localized osteoporosis because of the aggressiveness of the treatment that the patient had because of the cancer. So the patient had irradiation, and this is why these vertebrae are osteoporotic. So basically, the irradiation killed all the cells there, which are producing bone and which are responsible for holding good bone quality. So I think in that respect, we have to just accept that this is the situation. That is what we have to deal with. I'm not sure that teriparatide would improve that situation there, just because teriparatide is something that will activate the cells to produce more calcium there and to improve the bone quality.
It's contraindicated because
Correct.
of somebody having a
Tumor.
tumor before.
Tumor.
Otherwise, you're going
Correct.
to increase the chance of tumor coming back.
Correct.
So there's another question here. We can make lumbar stability, but how about the fusion? Did we do fusion here with MIS?
Right. So yeah, well, obviously you can see there that we are having interface between the two failing vertebrae. Yeah, so I don't have problem with the lower screws as well. So I'm hoping that yes. So with only opening isolated to do a minimal invasive, yes, you're compromising with putting more bone there and creating better fusion. But there is always trade-off one for another.
Okay, and there's another question. This is for Mehmet. What is your opinion of endoscopic L-lift or T-lift fusion?
Yeah. I'm not totally against it, but I'm not for it. Yeah, actually, it's really technically quite demanding to not to place a cage or graft, but to clean up the space in this space with endoscopic technique. Probably they will develop some techniques to make it efficiently, but after that, they will have good results. But now it's in the early phases. There are some surgeons who are very experienced in doing decompressive surgeries. They are also doing some interbody fusions using full endoscopy from a 1 centimeter diameter tube. But as I see, also the Nikolai is not doing endoscopic or MIS interbody fusion. Am I right, Nikolai? So
I do MIS, but I don't do endoscopic. At least in my hands. So as it was properly noted by the participant that was commenting on MIS and fusion. So if you are doing MIS screws, obviously you are not uncovering the spine enough to put bone there and to promote fusion that way. So you are relying on the interbody to fuse. This is where you're expecting the fusion to happen. So that is why I still don't do endoscopic fusion in my hands. I do endoscopic surgery. I do endoscopic decompressions now and endoscopic discectomies, but not fusions yet. I think, at least in my hands, what I'm having a surgical technique is not enough, and is further diminishing the chances of fusion to happen. So there is surgeons. So if you speak to Koreans, they're gonna tell you that the fusion endoscopic TILIF, for example, is something that they perform routinely. We probably have to wait and see their results, but not in my hands as it.
Dimitri here is suggesting that what they do is they do first step stabilization, and after 3 to 6 months they operate posterior lateral spondylosis. They remove the damaged bone and place implant after 3 to 6 months. What do you think about that?
Well, that's a stage surgery, so yeah, I think probably you can consider. I don't know. I don't do that. I don't do that. I don't know, Mehmet, what do you think?
Yeah, actually, my dear friend, Dr. Fahir Özer in Turkey, Istanbul, is implementing multi-level screws first, and after 3 to 4 months, he operates again and make fixation. By the time, because the screws are not getting any loads coming from the body movements or from the rope fixation, so then they have good integration to the bone. This is similar to the dentists are implanting making implants into the upper or lower chins, and after placing the implants, 3 to 4 months later, they place the prosthesis on it, because the integration of the implant with bone is achieved. We must think about those in the future more than today, because the bone quality, especially in the elderly, is not good. There is one question from Dr. In-Sang saying that posterior fusion with grafting on transverse process is now abandoned. Is it? No, it is not. But it is. It's like old-fashioned technique, and many surgeons do not use it. But there are still some surgeons who are using already without any implant, just placing grafts after good decortication. It is possible.
Aftab Yunus is asking, Aftab Yunus is asking, what is the best way of fusion at L5S1? Mehmet?
Is there a question for me?
Yeah,
for
everybody.
L5S1 is best way of fusion is interbody fusion. I'm sure for that. Actually, we must, if we are making it, especially for long fixations, if we are involving L5S1 level, we must always do an interbody fusion. It may be by a TILIF or by an ALIF. Both are possible.
Nikolai, for you?
Otherwise, the non-union rate is quite high, as you know.
I completely agree with that. L5S1 is the center of the gravity of your body. The shear forces there are the strongest. That is why we see L5S1 degenerating so much. And I agree that whatever you do, L5S1 interbody is probably the best way to do to achieve good fusion there.
One question about the DEXA scan. Do you do a DEXA scan in such cases which might help in planning the type of instrumentation? Someone, you can answer this.
Sorry, Mehmet, I missed your question.
DEXA scan and planning of the surgery.
Okay, so DEXA, the recommendations are that DEXA you could maybe use once every 3 years and not every week or month and 6 months, because it doesn't change that quickly. Second, obviously DEXA changes according to if you have been on calcium or vitamin D, etc. So you have to be careful on that. Also, if you've got some kind of implant, it's not going to give you exact reading. So there are many views that we have problems regarding that. So DEXA can help when there is an issue related to a typical osteoporosis and not when it's related to radiotherapy, because it can't again show you the exact reading, correct readings. But obviously judgment of the surgeon or the teaching physician comes into play. The problem is you cannot give any of the medications that we use for increasing the turnover of the cell, because if it's some kind of cancer or tumor, then you can again increase the likelihood of tumor coming back. And it's been shown in rats, etc. But obviously it's contraindicated when you have got somebody who's got a tumor in that area or a tumor anywhere in that particular person. So DEXA can be used if you do it in a person who hasn't had a tumor, doesn't have any problem with kidneys. Then in that person, yes, you can use DEXA. And if it's the osteoporotic bone and you have to operate, and if it's not urgent, then you need to give teriparatide to that patient for a minimum of 2 to 3 months. And then you can continue that afterwards as well, after surgery. So surgery can be performed in about 2 to 3 months. If patient can wait up till 6 months, then that's the best. But that's what we routinely do now, is 2 to 3 months of teriparatide before starting everything else. In the meantime, obviously physiotherapy and other things will help in improving osteoporosis as well. And vitamin D, other parameters of health, frailty needs to be corrected as well before you operate on these patients, because we know with frailty, the outcome, if worsening frailty, the outcome is bad. So we need to try to make these patients perfect or near perfect before you operate on them.
In that line of thoughts, what about measuring the Hansfield units of the vertebrae that you are going to address with screws? Do you believe in that, and do you apply that in your practice?
Actually, I don't apply in my practice, because no matter how many times you write to our guys that please measure, they forget to measure. So I don't use that, but yeah, it is helpful as well. Do you use it, Mehmet?
No.
Nikolai, do you use it?
Well, for me, it's an orientation of how bad or good is the bone. So yeah, if I have a CT scan, I would go there. It's a very simple thing to do. We can just go and select a region of interest and then see what is the Hansfield units. If it's below 100, you definitely expect problems. Obviously, if it's above 100 and 120, then you can go ahead and you'll probably be all right.
Sandeep is here. Sandeep, can you give us your comments? Please show us if you can show us.
Yeah. Actually, can you repeat that? I was away for a minute.
The question is, do you apply measuring the Hansfield units on a CT scan when you're planning how you will fuse somebody when you put screws? It started as DEXA scan, and then in that line of thoughts, now we are discussing measuring Hansfield units on a CT scan, and then reflecting that with you in your plan for fusion of the patient.
No, not really.
That's something that is obviously not the mainstream, is not approved. Still, at least here in UK, the mainstream is you send your patient to have a DEXA scan, and like that you have an orientation of how good or bad is the bone quality. But obviously you don't have DEXA scan for all of the patients that you operate. So for me, if there is a CT scan, I think this is a good orientation of if you have to expect problems or not.
Okay, very good. Any more questions? Nicola, have you told the audience why the three honored speakers are not here?
Yes, so we have explored what happened. And so when I was sending the invitations, I wrote 05/03/2023. So for me, this is 5th of March, 2023, but unfortunately, our speakers read it as May 3rd, 2023. So 05 for them was May, not 5th of March. So this is what happened exactly. It's obviously misunderstanding. I apologize for that. So what we have decided is that because they read it that it's May, so they have to present on May. So we will have the speakers in the beginning of May. So I think the first Sunday of May is 7th of May. So we will have the speakers from Cleveland, US, presenting to us on 7th of May, and it will be the same topics. So we'll discuss again based on their views and how they see things there.
Imad, can you share the poster for incoming thing?
Yes, sir.
Please.
Let me unshare here.
Yeah, please, yeah. Nikolai. Any more questions?
There are a few unanswered questions. One is that how do you choose which patient can go MIS fusion? I think if you are familiar with MIS fusions, you can do all patients with MIS fusion. But since it's technically demanding and it may take longer surgical durations, it's not done by many surgeons. However, the main advantage of MIS fusion is having less blood loss and having less injury to the muscles.
My answer to that is what is not. Sorry, Mehmet, I thought you finished. Please, excuse me for interrupting.
No, it's fine. Yeah, please, you can comment.
My answer to that is what is my approach to this is what is not. So the impossible things are the possible things which take longer time. So initially, when you start a certain technique, you're selective. Let's say minimal invasive. You do minimal invasive simple cases. Then after your experience comes, what you think it is impossible, 5 years later it becomes possible. So that's how it is.
Yeah.
If you this is what is valid for me. I do more and more things. Practically, I lately do mostly everything with minimal invasive techniques. I try to apply minimal invasive principles in literally everything that I do. That's valid for everybody. I always remember. So you see there on screen Kim, who is going to talk about endoscopic foraminoplasty. I remember that's for the next webinar. We'll make sure that they get the date properly. We will. So if I remember, I was speaking to him a couple of years ago. Kim, I asked him, when is the last? This was exactly in Athens, just before COVID, 2019. We were in Athens for a conference which Yanis organized, and I've asked him, when did you do last open and discectomy? And he said 5 years ago. And Kim has done probably over 2,000 endoscopic surgeries now. So all these speakers that you see on screen there, they are very, very active in endoscopic surgery, and they have many, many numbers. So it will be interesting webinar. So please join next time. It's going to be, I deliberately asked them to, because they're very experienced, they can present very, very sophisticated techniques of endoscopic surgery, but I have asked them to keep it to basics and to present us how to start doing these things which they are doing already. So I think it will be beneficial for everybody.
Nicola, there is another question for you. For fusion using exogenous graft filled with autologous bone graft, which is better? Bone dust preserved by using mucus, or that's this container that you're using?
Yeah, well, so I can, if I need small amount of bone, I get what is in the container and I put it back. If I need more, I will mix what I get from the container in master graft or any other autologous any other material that is available for me, and like that I make it more, and I believe I make it better because bone is always the gold standard.
Good. Mehmet, any more comments?
No,
Sandeep?
this is fine.
Yeah, but I must congratulate you both, Mehmet and Nikolai, that without the main speakers being present, it was a fantastic session and pretty useful for everybody.
Well,
Totally
I
agree.
hope it was good for everybody that was there with us today. We had at one moment it was over 150 participants. Thank you so much for participating. In the beginning was 152. Now it's 144. So we definitely kept you interested. So again, thank you for staying with us till the end.
And
Yeah,
listen,
I was muted all this time, so I could not participate. But
yeah. You disappeared on us. Don't give us that. Can we all switch on our cameras and so we can have a group photograph, please? Can we all, everybody, switch on their cameras, please? Thank you. Please switch on your cameras. Thank you.
Camera.
Thank you all the participants for being with us in that precious time.
Okay, switch on, everybody. Switch on your cameras, please. Brilliant. Imad, are you taking the pictures?
Yes, sir.
Thank you.
You're ready.
Goodbye.
Thank
All
you.
right, so we are all
Thank you.
set. Thank you very much. Bye-bye.
Bye-bye.